Okay, so we have started the preparation for medicine subject, and we have already discussed the CVS part 1 and 2, and also the we have started the respiration, that is pulmonology, and we have covered some topic in all of our first video. The rest of the respiratory unit we will discuss in this video. So we are having a topic pneumonia, and we are having a scenario that there is a 35-year-old male patient. Oh. Okay, so there is a scenario which said that there is a 35-year-old male, 1 week history of high grade fever and right sided chest pain and hemoptysis. On examination, temperature is 102°F and toxic looking. Pulse is 110 per minute, which is regular. Chest examination, bronchial breath sounds on right side. What is the diagnosis, investigation, the treatment, and complications? So the definition is that inflammation of lung parenchyma caused by acute infection and is characterized by consolidation both clinically and radiologically. The clinical features are high grade fever, malaise, delirium, sometimes severity, anorexia, fatigue, dry cough, pruritic chest pain for 2 days, cough first 2 days dry, then later become productive, tachycardia and tachypnea is present. The signs of pneumonia are decreased or absent breath sounds, that is dull percussion, bronchial breathing. Okay, the pneumonia classification is community acquired pneumonia, hospital acquired pneumonia, measles patient pneumonia, immunocompromised patient pneumonia, and aspiration pneumonia. The risks or causes of pneumonia are air pollution, old age, alcohol, upper respiratory tract infection caused to organisms, that is bacterial or viral. Then the important risk are streptococcus pneumonia, post respiratory infection, staph aureus, elderly, that is H influenza. Then the young patient, the mycoplasma pneumonia or atypical pneumonia, legionella associated with AZ, and Klebsiella, that is alcohol. These are the important risks or causes of pneumonia. Then there are the stages of pneumonia. These are acute exaggeration, gray hepatization, then red hepatization, and resolution state. Then we are having the management. Score is from the score we will manage the pneumonia. First of all, we are having the confusion. For confusion, we are having 1 point. Urea greater than 7 millimole per liter, then 1 point. If respiratory rate is greater than 30 per minute, then 1 point. BP is less than 90/60, 1 point. Age 65 or above, then 1 point. Management change, which is the curve scoring. So from 0 to 1, if the score is from 0 to 1, then home management. If it is 2, then hospitalize the patient. Intravenous oral antibiotics are given. If it is greater than 2 or 3 or 4 or 5, then it is the patient is admitted in the ICU. Now the principles of management of pneumonia are, that is general management, which is asked according to the curve score. Then mask of O2 and saturation of 92% is done. Then a continuous pass to end pressure is done. Fluid therapy, intravenous lines are given to normalize the patient. Antibiotics are given. Pleural pain, analgesic paracetamol, and for pleural pain, analgesic paracetamol and NSAIDs are given, and physiotherapy is done. The specific measures for the case of pneumonia are for regimen of antibiotic, which are amoxicillin 500 mg 3 times per day oral. Then first time, but now resistant is developed. So now erythromycin or clarithromycin is used. Erythromycin 500 mg 4 times per day, and clarithromycin 500 mg 2 times per day. SRES, penicillin, and macrolides are used. SRES is used in severe cases. Penicillin, fluoxetine, and macrolides 500 mg used. Atypical organisms, mycoplasma, legionella, and rifampicin plus clarithromycin is used. In severe pneumonia, penicillin plus macrolide plus cephalosporin plus coaxiglove is used. Now in OPD patient, azithromycin is given. Cap Asomax is given to 50 mg per day, or clarithromycin is given. Tab Glacidit 500 mg or Augmentin 625 mg. The duration of treatment is typically, for typical pneumonia it is 7 to 10 days, while for atypical pneumonia it is 2 to 3 weeks. Now if the patient is hospitalized, then the first option of treatment is amoxicillin and intravenous analgesics and clarithromycin injection. The option 2 is ceftriaxone and clarithromycin intravenously. The complications of pneumonia are empyema, bacteremia, meningitis, endocarditis, pericarditis, and pleural effusion. So up till now we have discussed the case of pneumonia, the scenario, then the definition, then what are the signs of pneumonia, then the clinical features, then the pneumonia classification, then the risk or causes of pneumonia, then the different stages of pneumonia, then the management options, which are curve score, then the principles of management, which are general and specific, then the regimen of antibiotic is given, then the treatment for OPD patient and for hospitalized patient, then the duration of treatment, and then what are the complications of pneumonia. Now coming towards our next topic, that is lung cancer or bronchogenic carcinoma. So we are having a scenario that there is a 60-year man history of having smoked 30 cigarettes per day for last 40 years, lost 10 kgs weight over last 3 months, and hoarse voice is present, shortness of breath is present, on and off blood streaks sputum is present. On examination, he is pale, finger clubbing is present, palpable axillary lymph nodes are present. Chest suspension decrease on right side and it has stony dullness percussion node on right side. What is the diagnosis, the differential diagnosis, the investigation, the management, and the counseling? The definition of lung carcinoma or bronchogenic carcinoma is that it most frequently diagnosed major cancer, most common cause of cancer mortality worldwide. The differential diagnosis of lung carcinoma are pulmonary TB, bronchiectasis, acute bronchitis, pneumonia, and FB. The clinical features are cough, hemoptysis, weight loss, dyspnea, hoarseness, and dysphagia. The risk factors of lung carcinoma are cigarette smoking, radiation, uranium and asbestos, and arsenic. The investigation options are chest X-ray, CT scan, which is useful for the detection of small tumors, identifying diagnosis in mediastinum and lymph nodes, and local spread of the tumors. Positron emission therapy is done. Investigation of size for assessment of mediastinum. Then MRI is done, which detects small masses. This is 1 to 2 centimeters. Cytology is done. Sputum and pleural fluid cytology to detect malignant cells. And bronchoscopy is done to get biopsy of tumor and to find whether operable or not. Then the percutaneous aspiration and biopsy is done for peripherally located. Okay. Now coming towards the management of the coming towards the management of the lung carcinoma. For non-small cancer, early stage surgical resection, that is main modality plus adjuvant chemotherapy. For advanced stage, chemotherapy is the main treatment of modality plus radiotherapy. Then bevacizumab, that is antivascular endothelial growth factor, can increase median survival rate by 2 months. Then for small cell cancer, usually disseminated at presentation, chemotherapy, that is primary treatment modality. Radiotherapy is added to chemotherapy, which improves survival, and prophylactic cranial irradiation improves survival. For malignant infusion, as a fusion caused by malignant disease reaccumulate rapidly, to avoid distress of the repeated respiration, one attempt should be made to obliterate pleural space. Then the chemical pleurodesis, that is instilled tel or doxycycline through chest tube after fluid drainage, and it will cause obliteration of the pleural space by creating an inflammatory reaction. The complications of the lung carcinoma are shortness of breath, hemoptysis, pleural effusion, metastasis, and hoarseness. The prognosis is very poor. Less than 10% patients survive 5 years after the diagnosis. So we have studied the lung carcinoma or bronchogenic carcinoma with a scenario. The main point for the carcinoma diagnosis is weight loss. Then we discuss the definition, the differential diagnosis, the clinical features, and the risk factors. Then we discuss the investigation options, which are chest X-ray, CT scan, PET, that is positron emission therapy, MRI, cytology, bronchoscopy, and percutaneous aspiration and biopsy. Then we discuss the management options, which are for early stage and advanced stage. Early stage is for non-small cancer. Then for small cell cancer, we discuss the treatment options. Then for the malignant effusion, then the chemical pleurodesis, and then we discuss the complications and the prognosis of the lung carcinoma. Now coming towards the next topic, that is pulmonary embolism. We are having a scenario that there is a 56-year-old female, fractured neck of female is present, and sudden shortness of breath on second day of her admission. She is non-diabetic, not hypertensive, no history of ischemic disease. On examination, cynos tachypnic with respiratory rate of 40 per minute, BP is 130 by 90 mm of Hg, and pulse is 120 per minute. Bilateral crackers in chest is present, and ECG shows sinus tachycardia. So what is the diagnosis, investigation, and treatment option? The definition of pulmonary embolism is that pulmonary embolism results from emboli arising from a thrombi in venous circulation or right side of the heart. More than 90% of the pulmonary emboli originate as thrombi in deep veins of the lower extremities. The causes of pulmonary embolism are DVT, pregnant pelvic area, intravenous catheter for long time. The risk factors of pulmonary embolism are COVID, bedridden patients like deformity, cancer, acquired or hereditary thrombophilic disorders. The clinical features for pulmonary embolism are use of OCPs, sudden pleuritic pain, dyspnea, decrease O2, decrease CO2 on ABGs. X-ray is normal and history of fracture of femur is present. Then we are having the Wells criteria, which calculate the risk for pulmonary embolism. DVT symptoms, if the DVT symptoms are present, then 3 points. If the patient is immobile, then 1.5 points. If the prior history is present, then also 1.5 points. Greater than 6 points shows the high risk of DVT. The investigations are baseline, then the chest x-ray is done. If watermark sign is present, then normally vascular marks present. In case of embolism, markings are absent, and Hampton hump is present, hump due to non-profuse area because of the decreased blood supply. Then EBGs are done. The partial pressure of O2 is decreased, partial pressure of CO2 is decreased, A to A gradient is increased than normal. Then ECG is done. The common finding is sinus tachycardia. Then D dimers are done, increase in thrombotic activity, increase in pregnancy, and increase in infection. Then CT pulmonary angiogram, which shows bright color dye injected. Ventilation and perfusion scan is done. Air in and the alveoli. Inhale radioactive material and check in X-ray. Then for perfusion scan, blood in vessels, radioactive material inject in vein and check in X-ray. Pulmonary angiogram is done. Dye is injected in femoral vein after sedation, and lower extremities Doppler ultrasound is done, in which angiography and pulmonary angiography is done, which are the gold standards. The management options. Okay, we have discussed investigations for pulmonary embolism. Now, the management options for pulmonary embolism are oxygen therapy. General measures: avoid things that increase heart strength, for example, positive inotropic drugs. No diuretics or vasodilators are used. Decrease CO and decrease fluid. Anticoagulation therapy is provided, that is heparin in case of suspected APTT to measure activity of intrinsic pathway factor. Then PT for extrinsic pathway. Heparin low molecular weight target therapy given in long-term pregnancy, not cross placenta. Okay, warfarin is given, act on vitamin K dependent factors, and PT extrinsic pathway, no pregnancy clause, and 3 to 6 months. In patients having protein CS deficiency, bleeding blood problems, thrombolytic therapy is given, that is streptokinase. The clinical features are sudden onset of shortness of breath, pleuritic chest pain, cough, hemoptysis, tachypnea, tachycardia, decreased breath sound, dullness on percussion, low grade fever, and sinus tachycardia. Okay, so we have discussed the pulmonary embolism, then its scenario that there is a female patient and having fracture of neck or femur. So, define the pulmonary embolism, then we discuss the causes and the risk factors, the clinical features, then the Wells criteria for the risk of the embolism, then we discuss the investigation options, which are baseline, chest x-ray, ABGs, ECG, D dimer, CT pulmonary angiogram, ventilation, perfusion scan, pulmonary angiogram, and lower extremity Doppler ultrasound. Then we discuss the management options and the clinical features. Now coming towards pleural effusion. We are having a scenario. Okay, we are having a scenario that there is a 30 years old patient, 3 weeks history of left-sided chest pain and shortness of breath and cough. He was advised chest x-ray which showed massive left side pleural effusion. 50-year man, smoker, history of right-sided chest pain, cough and dyspnea. Chest x-ray show right-sided pleural effusion. Signs of pleural effusion on chest examination, investigation, causes and clinical signs. We have to mention this. So the definition of pleural effusion is that it is abnormal accumulation of fluid in pleural space as a result of excessive exudation or transudation from pleural space. We are having transudate, that is clear appearance, and exudate, which is having purulent appearance. So transudate occurs when there is imbalance between hydrostatic and oncotic pressure. So fluid infiltration exceeds reabsorption. In exudative occurs as a result of inflammation of the pleural surface leading to increased capillary permeability. The causes of transudative pleural effusion is congestive cardiac failure, nephrotic syndrome, cirrhosis of the liver, hypothyroidism, and constrictive pericarditis. The causes of exudative pleural effusion are tuberculosis, bacterial pneumonia, carcinoma of bronchus, empyema, hemorrhagic effusion, chylous effusion, and acute pancreatitis. The clinical features are slowly building TB for months, TB having history of months, pneumonia 2 to 3 days history, liver cirrhosis, kidney failure, pain in chest start from moderate end with severe cough. The signs are hypoxia, increased breathing rate, palpation, less expansion at affected site, and resonant on percussion. The investigation options are chest x-ray, that is transudative or exudative. Then ultrasound is better transudative, echo in ultrasound because thin, and exudative no echo ultrasound because it is thick. Thoracocentesis is the best option. Then diagnostic test, pleural fluid aspirate under ultrasound or CT guidance is done. Biopsy is done. Then other tests are blood glucose, FBC, RH factor, pH of the pleural fluid, and serum amylase. Now the management option for pleural effusion asked that we have to treat the cause, that is if it is TB or pneumonia, then treat that. Therapeutic aspiration is done, treat the cause. Small effusion, no therapy except treat the cause. For large effusion, drainage by chest intubation less than 2 liters per day, and for TB, give anti-TB drugs. If pneumonia, then give antibiotics. On examination, inspection, palpation and percussion is done. On inspection, there will be decreased chest movement on affected side, may be bulging on affected side. On palpation, displacement of the trachea and decreased vocal fermentation is present. On percussion, stony dull percussion note is present. On auscultation, reduced vocal resonance or decreased or absent breath sounds are present. Okay, so we have discussed the topic pleural effusion, the scenario, then the definition, then the difference between transudative and exudative pleural effusion and the causes of both the types. Then we discuss the clinical features and the signs, then investigation options which are chest X-ray, ultrasound, thoracocentesis and biopsy and other tests, and we discuss the management options. Now coming towards the pneumothorax, we are having a scenario that there is a 20 years man smoker has presented to accident and emergency department with sudden onset of shortness of breath and left side chest pain. On examination, apprehensive pulse 130 per minute, regular BP 70 by 50 mm of Hg is present. On chest examination, trachea is displaced to right side with a hyperresonant percussion note on left side. Another scenario is that there is history of sudden onset of right side chest pain, increasing severe breathlessness for last 2 hours. Patient centrally cyanosis, restless, he is febrile. Pulse is 120 per minute, BP is 90 by 60 mm of Hg. Trachea is shifted to the left, chest movements are diminished on right side. On auscultation, breath sounds absent on right side. So what are the diagnosis, complication, investigation and treatment? The diagnostic points are dyspnea, breathlessness, mediastinal shift, absent lung sounds. Then the types are spontaneous pneumothorax and traumatic pneumothorax. On examination, absent breath sounds and percussion resonant is present. The investigation options are X-ray chest, that is complete translucency with no lung markings, then displaced mediastinum, then sharply defined of the deflated lungs. Then ABG is done with present hypoxemia and low partial pressure of O2 and increased partial pressure of CO2. Then the management option for pneumothorax is that if less pneumothorax can resolve itself, air respiration is done through needle in young age when no mediastinal shift or tension pneumothorax is present. Chest tube drainage is done. Lung disease in old age, increased pneumothorax at 3rd, 4th, 5th intercostal space at mid axillary line. Then pressure released by blunt cannula inserted in skin, air is sucked, then chest tube is used. Recover in 5 to 7 days. Surgery is done. Supplemental O2 is given. Help in air removal. Analgesia is given for pain relief and PP is maintained with intravenous fluids. The complications of pneumothorax are hypoxemic respiratory failure, cardiac arrest, respiratory arrest, pneumomediastinum, pneumopericardium and pulmonary edema. So we have discussed the topic pneumothorax along with the scenario, then the diagnostic points and the types, then the investigation options which are X-ray chest, ABGs, then the management options, and then we discuss the complications. So in this unit we have discussed all the topics. The first 5 topics, that is asthma, status asthmaticus, COPD, bronchiectasis and pulmonary TB is discussed in the first video, while the pneumonia, the lung cancer or bronchogenic carcinoma, pulmonary embolism, pleural effusion and pneumothorax are discussed in this video. In the next video we will discuss our next unit, that is endocrinology, which is a part of part A medicine. Thanks for watching.